Hello and greetings from Glasgow and Scotland. Thank you to all my friends in the Valparaiso Pediatric Society, and especially your Presidente, Giulia Cirandoni, Maria Pazmaran and Sandra Mazzano, for honouring me by asking me to talk to you about some of my recollections of over 40 years in paediatric dentistry. I remember very clearly my visit to your beautiful city and country in 2014. Pablo Neruda's house, overlooking the ocean, full of memorabilia that he'd collected from different countries. And I was intrigued that he had a number of pictures of ships that were manufactured and built in Glasgow. Then my walk through your city on one very hot afternoon, where I learnt that you weren't hippies, but you were actually all very happies. And of course, what visit to Valparaiso in Chile would be complete without an introduction to the national drink, Pisco Sour. So why dentistry? Well, there hadn't been a doctor or a dentist in my family. In fact, most of my relatives had been engineers, either in the shipyard or on board ships. We are from Newcastle upon Tyne, which is a shipbuilding city on the northeast coast of England. Shipbuilding as important to us as it is to Valparaiso or Glasgow. Whilst growing up, though, I wasn't really very interested in engineering, but I was interested in how the human body works, and I made probably hundreds of models of aeroplanes and ships in plastic and balsa wood. So this manual dexterity, together with an interest in the working of the human body, and also a liking for speaking to people, led me to consider a career in dentistry. When I was interviewed for a position in dentistry at the University of Newcastle upon Tyne, the Dean of Dentistry at that time, Professor Roy Storer, gave me one of the most important pieces of advice anybody has ever given me in my whole career. He said, never give up on your interests and hobbies outside of dentistry. You should work in dentistry in order to live. You shouldn't live for dentistry. And I have passed on that information to as many students as I could. So I started my undergraduate career in 1973. Was there an anterior restorative material at that time? Well, there was. It was a silicate cement of universal colour and not very comparable to any enamel or dentine colour. Composites didn't start in our clinics until about 1976, and they were a universal shade composite, and they had to set against a celluloid matrix strip in order for them to be smooth. They had a very high filler content, and if they didn't set against the matrix strip, it was as rough as the grains of sand on the beach, and it was not polishable. But they were an improvement over silicates, because prior to them, if you were a child with an enamel dentine fracture on your upper central incisor, the only way of restoring it was by making a gold crown to fit over the tooth, cutting out the labial face of the gold crown, and then filling that with silicate. The gold part was called a basket crown. You might find those in some dental encyclopedia. So it was good to have a composite in 1976. And what did we have at that stage for posterior teeth? Well, only amalgam and gold. But by the mid-1980s, there had been a huge expansion in composite technology. There were colours and shades available for dentine and enamel and translucency for enamel tips. And there was the first posterior composite as well. I was very fortunate to be involved in clinical research into compomers, composites and glasionomer cements in the mid-1980s because there was such an interest in that topic at the time. However, the use of all these new materials was only made possible by our increased understanding of bonding of these materials to tooth tissue. I can safely say that I would not have liked to have been a pediatric dentist before the advent of acid etch technique or composites. So after dental qualification, I worked as an oral surgery resident, and I got very interested in maxillofacial surgery as a possible career. And I then studied medicine and funded my way through medicine by working as a general dental practitioner, evenings and weekends. I qualified in medicine in 1984 and did jobs in general medicine, general surgery, accident and emergency, and plastic surgery. But by that time, I had 3 young children, and I suddenly thought that I'm never going to see them. So an opportunity came up to do a PhD in the dental school in Newcastle under the tutelage of Professor John Murray. And when I was back there, I suddenly realized how much I had missed the intricate or intraoral work of dentistry. However, I'm certain that my experience in medicine has made a lot of things more possible for me in pediatric dentistry and has proved invaluable to me in my treatment of children with medical illnesses. I've looked after children with cancer and oral mucositis now for over 30 years. And until 2012, the treatment of oral mucositis was a lottery. And it still is in many cases. But we started using in Glasgow in 2012 the low-level light laser, diode laser, 830 nanometers light, and that has, to me, has revolutionized the treatment of oral mucositis. It's probably the most significant improvement in oral care for cancer patients in my practicing lifetime. We're working with other units to get it more generally used, and I can assure you that if you do use it, the pediatricians, the pediatric nurses, the parents and the children will very quickly notice a huge improvement in their lifestyle. We now have a greater knowledge of pulp treatment in primary and young permanent teeth compared to what we had. We can now keep teeth with deep cavities. They no longer need to be extracted. We can reduce the number of orthodontic treatments children need in adolescence by retaining primary molars. And we can keep avulsed teeth much better than we used to be able to by our knowledge of the resorptive process. The patient I remember most when I think about my trauma patients was a 12-year-old girl who was kicked in the mouth by a horse, and she lost all her maxillary 10 anterior teeth. However, they were all replanted. We looked after them all, we retained them all with reasonable root lengths, and we passed her to our restorative colleagues at the age of 17 with a full dentition. She'd not required any bleaching or anterior composites in addition to root treatments, and our restorative colleagues will continue to look after her and consider implants in the future. So that was a memorable treatment. When I started dentistry, there wasn't fluoridated toothpaste. Can you believe that? So fluoridated toothpaste didn't come in until 1976. Prevention is now the most important part of all our practice, and getting the message across to parents and the public is our most difficult job. If adults can't control their sugar intake, then there's little hope that they will be able to control the sugar intake of their own children. That's the problem. In our current COVID epidemic situation, prevention is going to prove to be absolutely critical. But wherever prevention occurs, whenever it occurs, it has to be coupled with high quality treatment and continuing care. Behaviour management is something that's changed drastically. I never had any teaching or lectures on behaviour management in the 1970s, and yet our students now, it's an integral part of their undergraduate education, and quite rightly so. When I was a dental student, the thought of treating children used to frighten me. I didn't know how children worked. I didn't have any relatives who had any young children. And it wasn't actually until I had my own children that I began to understand how children worked and what a joy they were to treat. And that was one of the factors which helped me decide to be a pediatric dentist. One of the things that we have now, which we don't have before, are the adjuncts to behaviour management, like nitrous oxide sedation for the over 4 to 5-year-olds, like intravenous sedation for the 12 plus teenagers, and a knowledge of hypnosis. All of these are very valuable as possible ways to help children and adolescents who are anxious of a dental treatment. Nitrous oxide started in the UK. We started using it in Newcastle in the early 1980s, and most units in the UK had it by the end of the 1980s, and the challenge now is to get it more in general dental practices. Intravenous sedation, we require the help of an anaesthetist, but that can be a very successful way of treating adolescents with a significant fear. Hypnosis, lastly, is something now I would recommend all trainees to go on a hypnosis course now, because it's an absolutely essential part of behaviour management. So I think in reflection, all those aspects of behaviour management need to be considered together, and if you belong to a unit that has all these facilities, we need to utilize them all to help the children and the adolescents who come to see us. One thing that has changed, and I think you'll agree, sometimes mostly for the better, is the information we get on the internet, but sometimes that information can work against us when parents and children have searched the internet and they think that their particular case merits a particular treatment. And it can be difficult at times to explain to them that all the treatments available on the internet aren't applicable to every single clinical case. Towards the end of my time at Glasgow, around about 2012, 2010 again, we became aware of the wand injection system. And we incorporated this into all our clinics by 2012. And that is really an essential part of the behaviour management spectrum. So for anybody who hasn't used the wand, I would commend it to you. It's a near painless injection by a very small needle that can be held in the palm of your hand in a very non-frightening way. I couldn't finish by talking about the effect that hospital managers can have on our working lives because of financial constraints. And it's a difficult one, but we have to resist their intervention when they try to tell us how long we have got to treat children in the clinical scenario. We have to be able to control our clinical scenarios. So dental appointments for children have to be long enough to manage a child's behaviour and to restore teeth, not just to extract teeth. Dental appointments for restorations need to be at least 30 minutes and more likely up to 60 minutes long. So in coming to the end, my career highlights have to be the children we've treated and which we are privileged to have treated, and also the friendships that I have been able to make through meeting colleagues throughout the world during my time in lecturing and teaching. And the thing is that all of us are the same. We work tirelessly to improve children's oral health, and the thing that really was apparent to me is that wherever I went, we all had the same challenges. So, in finishing, thank you most warmly again for doing me the honour of being able to speak to you tonight. I hope you've been able to understand my English. I'm afraid my Spanish lessons haven't progressed sufficiently to allow me to speak to you in Spanish. I'd like to wish you good health, good luck, and continuing happy career. And with your glass of pisco, salud. And finally, in these days of COVID, it's difficult to know how things are going to progress. But the important thing is to maintain a sense of humour, look after your friends and colleagues, and enjoy each other's company, and stay safe. And I hope that your face covering is of a Chilean flag, whilst mine, of course, has to be of tartan.